Hi, this is Chris Sepper from Med City News. I hope you're all doing well. We're here back again for a regular edition of MedHeads, where MedCityNews.com journalists talk about the week that was in the area of healthcare innovation. We're actually going to stick on a tech theme this week, both talking about the American Telemedicine Association conference, but also the Fitbit IPO. Two big moves in wearables and telehealth happened this week that really are where we're going to spend most of our time. Joining me this week are the MedCity's two tech reporters, Stephanie Baum, who's based in Philadelphia, and Neil Vercel, living comfortably in Chicago, a fan of the Blackhawks, if I'm judging those tweets correctly.
That's correct. We swept the Minnesota Wild, so I don't want to offend our viewers in Minnesota, but bring on the Ducks.
So, Stephanie, let's bring on the IPO. So, you wrote almost immediately when news broke about Fitbit going public. They're going to raise $100 million, and you've written a couple stories since then. Give us the rundown. Give us the basics on what's happening with Fitbit and their IPO.
Sure. Well, this is kind of an interesting time because it's Fitbit is one of the pioneers in wearables, and especially in the area of fitness activity trackers. They last year, according to their S1, their revenues were $745 million on the back of net income of $132 million, and according to their S1, and they attributed this to a market research group, that they have 68% of the market. So they're really well positioned to be going to market, and I think Reuters was the first media outlet that had tapped sources that informed them that this is going to happen this year. So it seems like the waiting to bring their product to market, to go public, has paid off. Investors seem to be really excited about this. One story I saw this afternoon said this company is everything. This kind of IPO is everything that investors are looking for.
So, Neil, you've written about the wearable space for some time. And so you've got a point of view about these guys. Let it rip.
Yeah, I mean, I think in many ways these fitness trackers are not really health trackers yet. We're probably headed that way, but right now, I mean, this is definitely a consumer-facing fitness product, not a health or healthcare product. Certainly, fitness has an impact, has a bearing on overall health, but this is a fitness product. Right now, the data, doesn't really connect to anything within the healthcare ecosystem, to use an overused cliche of late, but so it really is of limited clinical use for anyone trying to manage a chronic disease or trying to lose weight or trying to get in shape under supervision of a doctor or a nurse or a health plan. So right now these products are glorified toys. They're very expensive glorified toys, but they're very popular. So I think eventually there's going to have to be some integration with EHRs or at least PHRs, and as we know, PHRs, personal health records, haven't really had much of an impact on any market anywhere unless they're tied closely to an organizational EHR. So, good for Fitbit, good for their investors, but it's from somebody who covers health IT and digital health. I'm still I think that the Teladoc IPO that was announced or that was hinted at earlier this month is probably more significant.
Well, Stephanie, what's your take on this? I mean, I'd have to agree that that 68% market share is of a market share of largely worried well or people who get them for Christmas and shelve them. I'd love to know, kind of like how Twitter had to do, like, all right, you have 68% of the market, but how many active users of your market base, right? But I think I've got a wearable somewhere in my study here that I'm never going to use again. But honestly, like, what do you think is? I mean, is this the king of wearable IPOs, or what? And how good of a stock is this if you're buying based off quality and potential in the marketplace?
I mean, I think that the as it said in its registration document, it's counting a lot on, going beyond the worried well. It's also counting on employer wellness programs and the growth of those programs, and in line with that, insurers. It's not. Yeah, I agree with Neil as far as the clinical applications. It probably falls a little bit short of the consistency that they would require and the sophistication they would require.
Good
But
point.
as far as just a really general sort of measure of people's activity levels, it can be a motivating factor. There was an interesting pilot study with Biogen, IDEC, and patients like me, and although it did come down to the fact that the data wasn't the accuracy wasn't of its data wasn't consistent, it did engage that population. It did make them more interested in seeing, okay, what was my performance like for like the entire week between doctor's appointments, and that can resonate a lot with different communities. And when you think about the people with chronic conditions and trying to motivate them, if they're if on your own, I could understand that there'd be like a huge fall off rate because you just get tired of it after a while. But if you see that it's helping you kind of track your progress, then maybe there's something to that for people with chronic conditions.
Okay, so you'd buy this stock.
Sorry?
You'd buy this stock.
I would buy the stock if I can afford it. The thing is, they're doing $100 million IPO, but the Wall Street Journal article, I think I referenced in my article yesterday, it doesn't. I mean, and a lot of other sources don't expect it to. They expect it to be much bigger, and it's going to generate a huge amount of interest, even if it's short-termism. Not for like many years to come. So that'll probably, maybe it'll do really well in the first couple of years, but then, it'll settle down after a while. We'll see.
Yeah, I have to say that's the one thing that reacted. I mean, they're doing $732 million in rev, and they've got $100 million in IPO. I mean, the valuation would have to be a little bit crazy, or the stock price. So it's not a ton. They could raise more money probably and be comfortable about it, but who knows? Neil, you just touched on a little bit Teladoc.
Right.
It's been kind of in the beginning of the year. We had a lot of life science IPOs and a lot of buzz around that, and now it's kind of been tech IPOs. We can, Stephanie, you wrote about Evolent Health, right?
Mm-hmm.
And now Fitbit, but there was Teladoc also that broke, and we just came back from the American Telemedicine Association conference. Neil, you were, and I was there doing a lot of interviews and panel things, but you were really on the ground talking to folks.
Yeah.
What was that like? What's your take on it?
Well, it's gotten to be a pretty big event. They drew 5,000 people this year, which I think is they said is a record. And interestingly, the new president of the ATA, who is Reed Tuckson, a lot of you know from United Healthcare. He left United a couple of years ago and has gone into consulting, and now he's been installed as president for the next year of the ATA. He made it a point during his inaugural address to make sure that everybody knew that he believes that telehealth is now mainstream and it's just another form of health care. There was some interesting discussion about why telehealth and telemedicine seems to be held to a higher standard, that somehow it's needs to be proved that it's safer than regular health care, traditional in-person health care, before some will embrace it. Well, the point was made that traditional healthcare isn't very safe to begin with. I mean, the only studies have shown that doctors only follow recommended protocols about 50% of the time for a lot of common procedures and diseases. So, why are practitioners of telehealth held to a higher standard? That was a question on a lot of people's minds during the keynote on Tuesday morning in particular.
Well, one of the reasons keynotes are held to, telemedicine is held to a higher standard. The data isn't there, right? I mean, the telemedicine folks talk a good game, and it's clear that I would much rather Skype with my doctor, which you can't do, by the way, because it's a HIPAA violation. I would rather Skype with my doctor.
Well, unless you give consent, but most doctors aren't going to do it unless it's an emergency.
Exactly. But I would much rather Skype with my doctor over half a dozen things that I might have to go see them with, and I'd much rather have a system where I could do some things from my home and send data. But that just can't. But there's not evidence in many cases that telemedicine is going to, make you healthier or keep you as healthier. That data is coming, but it isn't there yet. And Stephanie, I mean, a lot of startups take beatdowns from this, because they're going into a field that isn't as kind of evidence-based yet, even if the benefits are somewhat obvious. What do you see when it comes to telehealth?
I mean, it's interesting. You do see certain companies. These aren't necessarily startups either, that say, hey, if you take a picture of this, this imperfection on your skin, we'll be able to tell you whether you should have bother to make an appointment with a dermatologist and look at it or not. But you also have companies that are taking kind of playing the long game with that. I mean, I'm thinking of a company that I spoke to pretty recently called 3Derm that they actually explored going down the smartphone route of like taking a picture of your skin lesion and having a dermatologist look it over and see if they determined that it needed a biopsy or needed to be looked at closer, and they said they did a trial of this and they often missed it, and that's what inspired them to raise money to develop a more specialized tool to do a better job of spotting this. And it's not just people taking their own pictures of their skin irregularities. It's having a primary care physician operate this kind of camera equipment and send it to a dermatologist in hope. Their idea is that it will be something like what teleradiology has become. Obviously, there's a lot of interest in developing these specialized aspects of telemedicine, because how many companies can just like compete, doing direct to consumer, or even doing it through a retail clinic, or even doing it through an insurer, or as in the case of I was going to say Verizon, but they're not. But there's only so many ways you can differentiate yourself. So that I've definitely seen a lot more in the way of specialization in the last couple of years. But there's also much more of a, in some cases, there's definitely a softly approach, and there's definitely a more caution because they don't want to just be a Me Too. In some cases.
Yeah, and I have to say that you mentioned the business-to-consumer thing. I brought that up with a lot of early-stage companies, and there was one derm startup I talked to. Stephanie, you remember?
3Derm?
Yeah, 3Derm. And so 3Derm was really interesting. They talked about, they are essentially a B2B derm play, where they're typically being bought by large family practices to take high-res 3D images that are even better than what you can get with your phone. And the CEO there actually said some what I thought were pretty insightful things, that you can do a B2C play in telederm, but it's not typically going to be medically good. It's not going to pass the smell test for medical excellence of an image. They do 3D imagery. Mm-hmm. And she's a millennial, and she said something that while millennials want telemedicine, we have this video actually on MedCity's YouTube channel, and I think Neil, you refreshed it in one of our posts.
Yes.
She said that millennials don't just want it fast, they want the quality, and that right now, when you talk about a direct-to-consumer telemedicine play, you're actually not going to get the quality that you need, which I thought was interesting. I don't know if anybody else had insights on that direct-to-consumer part of it.
Mm-hmm. Yeah, I mean, direct-to-consumer is still in its infancy in healthcare. It really is, because right now, let's face it, most of the payments go through third parties, insurance companies or self-insured companies, and people aren't used to paying things out of pocket, or they don't like to to pay for healthcare out of pocket if they can help it. So unless it's unless it's going to be the most convenient thing for them ever, they're not going to spend the money on anything direct to consumer. Some of the retail clinics that you see at CVS, Walgreens, etc., have done pretty well, but they do accept insurance.
Well, I'd say that one of the things that's the biggest elephant in the room, I think, with telemedicine, and I think that I'll be straightforward. The telemedicine folks, I think, kind of bluff on is the state of regulation.
Yes.
I mean, I think it's still a mess, and
very much so.
Yeah, and so it's it'd be interesting to hear how you think it affects it. I mean, almost every state defines telemedicine or telehealth differently than another state. The consensus amongst legal types is that it's illegal to have some kind of federal licensure for telemedicine. So how are you going to actually get some level of consistency where you're going to be able to talk to a doctor from one state to the other, right? I'll keep using myself here, right? If I go on vacation to Oklahoma and I break my leg and I want to talk to my doctor about it, and he's in Cleveland, well, I'm kind of screwed if I'm going to try to use telemedicine in those cases. And most of those that state-to-state thing, you are kind of screwed.
You are, unless you're in a state that either has where your doctor just happens to be licensed in or have reciprocal privileges in, and that's one thing that they're talking about, is getting more states to recognize to grant reciprocal privileges. And then another one is there are some states, although it's the minority still, that do allow doctors to treat patients in other states. In most states, though, I believe the state where the patient is physically located is where the doctor has to be licensed.
I'd be curious from getting from you, Neil or Chris, what I've seen in legislation to some extent is does a physician's assistant or does a nurse's assistant need to be in the same room as the patient, and that it seems like that more than anything else will kind of determine the feasibility of direct to consumer, because I know in some states, again, some states are much more open about that than others. Was that a topic of conversation at the ATA?
I didn't hear anything.
Neil, I'll let you take that.
Yeah, I didn't hear anything personally, but that doesn't mean it didn't happen. Believe it or not, I didn't hear every word that was spoken the whole time.
No, I believe that.
Yeah.
Yeah, you kind of ground out there for a little bit, Stephanie. Well, let's move another direction. And Stephanie, I want to go back to Fitbit a little bit.
Okay.
I mean, is this going to be the first wearable IPO of many? I mean, there are a ton of wearables out there, right? But is this going to allow multiple wearables to go out, and how would you see that happening if it did?
Well, the thing is that a lot of the core competition with a Fitbit, they're already public companies. Look at Apple. I mean, they're publicly traded, and they've got Apple Watch, Garmin. What are some of the other ones? Microsoft. That's just a handful. I mean, I think they're going to be closely watched for sure. But at the same time, a lot of them don't have that kind of market share, and maybe they will kind of see how they do, and then maybe try to ride the coattails of that kind of excitement. But the sort of the classic challenges of doing an IPO don't fly out the window just because everything goes well for Fitbit, if it does in fact go well for them. So I think there's going to be a lot of waiting and seeing. I think it's a kind of an exciting time covering this area, because it'll be interesting to see how they do.
Well, nothing like a crackling Google Hangout on air to warn you that we should have to wrap it up. I think we've covered two of the most important spaces happening in healthcare this week: wearables, telehealth. I think it's going to be fascinating. Neil, do you want to take us? You got one more take to bring us home?
Yeah, I do. I want to say that there's still some, there was a lot of talk about what face-to-face means. Does it mean in person, or does it mean through a video connection where you can actually see the other person's face? And I think that might have been, from some things that I've read, might have been at the crux of the new Texas regulation, one that actually Teladoc has been fighting for a couple of years, I understand. One of the ATA keynotes on Sunday was Dr. Sanjay Gupta from CNN, and he talked about how he believes that telemedicine, telehealth, preserves what he called a human connection. Even though it's not in person, you can see the other person, and you can get the feedback. You can read the body language, that sort of thing that you wouldn't necessarily get on the phone or via text. So I found that interesting, and in fact, he told a very interesting story that doctors have been diagnosing from afar for a long time, and he brought up Dr. James Parkinson, who Parkinson's disease is named after. Almost 200 years ago, Parkinson wrote an essay about tremors just by observing people walking through a park, and Gupta said that Parkinson only physically examined 2 patients with that disease in his entire career. So this was 1817.
Well, it's definitely a new world for healthcare, because gosh darn it, too much. There wasn't enough regulation back then.
Yeah, exactly.
Well, hey, I want to thank everybody for watching MedHeads this week again. I'm Chris Sepper. I'm in my own home study, as you can see. Stephanie Baum in Philadelphia, Neil Versell in Chicago. Thanks again, everybody, for reading MedCity News and watching this program. We look forward to seeing you again next week. Take care, everyone.
Thank you.